there's this notion that, well, if you came to the emergency department and then you walk back out, you probably had a minor thing anyway. And that's not true. Only 5% of the patients that come here actually need to see a doctor. The problem is you don't know which 5%.
Exactly.
If they walk out before we see them, that's called left without being seen. And that's sort of a reflection of we didn't do a good job. Maybe because it's not possible for us to have done a good enough job because of the amount of space and staff we have. And I have personally been told by someone, I came to your emergency department and I left because I was too sick to wait.
Healthcare is the number one issue. It's a $7 trillion business per year.
It means that someone's on the receiving end of that $7 trillion, and they don't want it to change. All of the pigs at the trough want to have their food.
Exactly.
And so they will do everything they can to preserve the status quo and prevent it from changing.
Welcome to Health Frontiers with Dr. Bob. I am Dr. Bob, and today we have a wonderful show planned for you all. And we are honored to have Dr. Peter Viccellio, who is the Director of Emergency Medicine at the Stony Brook University. And Dr. Viccellio has an extensive background, over 40 years, in emergency medicine. He has been professor of ER medicine for the last 10 years at the medical school. He trained at MIT and then went to Harvard Medical School and has been boarded in both emergency medicine and internal medicine. And we are just excited to have him because there's such an emphasis today on emergency medicine, both in the popular media as well as in hospital management. So welcome, Dr. Viccellio. It's good to see you.
Well, it's great to see you too. Thanks for having me.
Thanks for being on. Let me start by asking a few questions that are very pertinent. What have been the changes to emergency medicine since its inception as a distinct specialty? And when did it become a specialty?
So it officially started as a specialty maybe a few years before I got into it. I grandfathered into it because at that time there was only a handful of emergency residency-trained physicians in the country.
Yes.
And starting from 1980, where emergency departments were basically covered by residents, moonlighters, and that sort of stuff,
yes.
The specialty has grown to the point where most emergency departments in the country now are staffed by board-eligible, board-certified, residency-trained emergency physicians. And along with that, there have just been dramatic changes in the scope of practice, in the technology, in the stuff that we can offer, the interventions that we can do, that has made it a much more fascinating and challenging specialty than it was at the time that I began.
Yes, I can remember and I can relate to that because a little bit of what people don't know is my early days at the New York Hospital in Manhattan, which is now Weill Cornell. I was moonlighting at night when I was a fellow, and I ran the emergency room medical department at night at the New York Hospital. And I had next to me a surgeon, and both of us did triage. But we knew nothing about emergency medicine. I knew internal medicine, and he knew basic surgery. And in the side room, they had a radio, and the radio was attached to a couple of ambulances that floated around Manhattan. And I imagine they were our first paramedic units in New York City. So it's a very exciting specialty now, and it's come a long way since 1972. That's for sure.
Well, when I trained in medicine, we were the diagnosticians. If somebody came to the emergency department, they were hypotensive, febrile, looked like they were in septic shock. As they were putting in the IV, they would call us for the admission, and we would come and take the patient and figure out what was going on. Now all of that stuff happens in the emergency department, and we've become sort of the epicenter for a diagnosis of undifferentiated illness.
That's wonderful. And I know that from my experience with the university hospital, because everybody that they send to us as specialists are already diagnosed and sometimes even treated. So how have hospitals changed over the past 50 years? And I guess it's been about 50 years for ER medicine.
Let me start actually by saying So the growth in emergency medicine has been tremendous in terms of the volume of patients seen. I looked up some statistics from 2022 that 47 out of every 100 people in the United States went to an emergency department that year.
Wow.
And I think it was about 8 out of those 100 got admitted to the hospital. But if you look at what's happened to hospitals, when I was a kid, my father was a GP, and there was nothing you would do for strokes or heart attacks. He would just, they would be treated at home. So you came in if you needed your gallbladder fixed or appendix out, or if you had some orthopedic procedure, or you needed to rest or have your blood pressure managed. But there was nothing you could do for very many things. So most of the admissions were elective, and it made sense to have a hospital system that ran 9 to 5, Monday through Friday,
Right.
with the skeleton crew on evenings, nights, and weekends.
Yes.
And things have so dramatically changed in the volume of patients, in the severity of their illness, in the complexity of their illness. And yet, in so many ways, we still are a 9 to 5, Monday through Friday system trying to answer a 7-day-a-week problem.
I agree.
There's a big mismatch between what we currently need and what we're actually doing.
Exactly. And that's why hospitals are in trouble. And we know that for a fact. ERs are crowded beyond belief. Is the problem the lack of primary care physicians? Are patients coming in for prescriptions and minor stuff like cuts and bruises, or are they coming in for serious, serious conditions?
So when I started, I would say about 10% of our patients would get admitted. In our particular institution, we admit close to 30% now. So the patient population is much sicker. Minor stuff is only minor once you've seen it and you know it's minor. That simple cut may also include a tendon laceration, or you might get an osteomyelitis underneath it, or something like that. A simple, quote, viral illness may be, in our area, end up being Lyme's disease or babesiosis or something like that. Right. So things that on the surface look simple often are not simple. That being said, we have so many, urgent care has grown so much, there's practically one on every block. So people with minor things tend to go there. And if there's any complexity to it at all, they just simply send the patients to us. But in terms of hospital crowding, in terms of emergency department crowding, in terms of long waits, we are not being brought to our knees by sprained ankles at all. It's because we have too many sick patients, and we're holding a lot of admitted patients in the emergency department, so we can't move them to somewhere else.
Now, are the emergency rooms a substitute for primary care doctors? You know, we have a big shortage of primary care physicians, and I hear from my patients, I can't get a hold of my primary care physician if they have one, but many of them say, we don't have a primary care physician. We're going to the ER. What do you make of that? I mean, that's everywhere.
So for acute primary care problems, we're just as good a place to come as anywhere, if not better. For chronic primary care, absolutely not. We are not primary care providers. And you asked the question about, are people showing up for prescriptions or stuff like that? We actually did a study on this. We had 1,000 consecutive patients where a resident sat at triage, and the nurse was asked if they think the patient's there just for a prescription refill. And then when the attending saw them in the emergency department, they were asked the same thing, if that's really the reason for the patient being here. And out of 1,000 patients, 10 were there just for prescription refills. Of those 10, 7 were admitted because the prescription they needed were like, for instance, medicines for diabetes, which they didn't have, so now their diabetes was out of control. So that's just one example. But the other thing we see as a result of not having primary care is that people present late in their illness. They didn't get their diabetes and hypertension treated, so that they now are having a heart attack or a stroke, or they have gangrene of a foot and have to have their leg amputated. We see people that come in with, I've had this lump and I've had it for a year and it's getting bigger and bigger and I've not been able to get anybody to see it, and now they have metastatic cancer. So the lack of primary care is can have profound effects on people that don't have access.
What about people who have no health insurance? I hear this all the time. I don't have health insurance, so I don't have a doctor. I can't come to you in the clinic because this is an emergency and I have to go to the emergency room. What do you think of that?
Well, there's a simple reason they come to the emergency department is that we're not going to turn anybody away.
Right.
Anybody that comes, we're going to see them and we're going to take care of them. We're going to make sure that they don't have an emergency. And if they do, we're going to treat the emergency. So we are the place to come if you don't have insurance. However, let me give you an example. I'm a construction worker. Maybe I make 60, 70 grand a year. I have a family with 3 kids, and to buy health insurance premiums for everyone may cost me $15,000 or $20,000 a year. I just can't divert that money to pay for the insurance. And now look what happened. On the work site, I hurt my back. I have a slip disc. I have severe radiculopathy, pain radiating down my leg. I am incapacitated. I come to the emergency department, get pain meds. The emergency department says, well, you need to have that operated on. But no one's going to operate on them because they don't have insurance. Yes. I guess somebody could say, you know what, we'll fix it, but it's going to cost you about $200,000 worth of physician's fees and hospital fees and this sort of thing. So they don't get it fixed. So what happens then? They're still in pain. They come back to the emergency department. They're given more pain meds and more pain meds. Now we've taken someone that was a productive member of society, turned them into an addict, and incapacitated them. They are no longer earner, and they now finally they qualify for Medicaid and for welfare. But it's because that they didn't have insurance that happened.
Yes,
I think it's about a third of bankruptcies in the United States are because of medical bills. It's a terrible, horrible problem.
This is a major health care among voters. And I think the politicians should see this show and be listening. Healthcare is the primary interest of people because many, many people have this very problem, like the example you just gave. This is catastrophic. It's healthcare. And, a worse situation is if your little child gets leukemia and they come in and they're ecchymotic, which means hemorrhages under the skin and stuff. Nobody knows why. The child's running a fever, and it winds up the child has leukemia, and they're looking at hundreds of thousands of dollars in costs. It's even worse if you're an immigrant and you don't have Social Security numbers, and you're having a big problem because, like, we doctors have to take care of everybody. We don't turn anybody away. There are laws against that. Wouldn't you agree, Peter?
Yes. There's the EMTALA laws. I think it's the best thing that ever happened to emergency medicine because it ended forever the dispute of, does insurance have anything to do with whether or not I take care of you today? Right. I love the specialty for that. I would hate having to do wallet biopsies on the patients that I see. But when I refer them, it becomes an issue. Right. Of a good friend of mine had a urinary tract obstruction, and we had to put a Foley in him and referred him to an outside urologist. So he calls the office to make an appointment. He can't get an appointment because he doesn't have the $200 or $300 down payment that they insist for him to go there, because he was a construction worker and he wasn't working because he had this illness. So he didn't go. So what does he do? He shows back up to our emergency department about a week later in septic shock, goes into renal failure, has to go on dialysis, finally decides, I don't want to live a life with dialysis, and he just stops and he dies a couple of weeks later.
Wow.
All because he didn't have the copay.
That's amazing. That's unbelievable. So let's switch gears a little bit and talk about what was it like to be at the epicenter of the COVID-19 pandemic? Did the masks work? Was it availability of PPE? What happened to the emergency room during this time? I know what happened to our emergency room, but I want to hear it from you.
So when we got news of this thing spreading from China, and the first thing I heard other than it was spreading was that there was a nursing home in Seattle where 10 people died in one place. And so I knew that this was going to be potentially something that could get out of hand and really unravel very quickly. We'd had experience with SARS-2 and SARS-1, and they were well contained. We had probably a more aggressive public health response to it at those times. But also, it is spread in so many areas of the world that it was hard to control all the entry points. So the strategy, as this blew up in many, many places, was, okay, we're going to have to sort out the people that come in with infectious symptoms from the people that come in with sprained ankles. And if you see the patients with infectious symptoms, you have to wear a mask and be careful and this sort of stuff. But you're okay with the sprained ankle. And a lot of hospital administrators were saying, we don't want you to wear a mask all the time because it's going to scare the patients. Our hospital was not like that. They wanted to be us to be safe, and they wanted the patients to be safe.
Thank God for that.
Well, my logic was, if it's a virus like other viruses, people get killed by it, they get sick from it, they may have a minor illness, or they may be asymptomatic. So if COVID's in our community, from this point on, we're going to wear masks all shift long, always, with every single patient. Now, they didn't adopt that in New York City. They had a different process at first.
Yes.
So I can give you the results of what happened at some institutions in the city and compare that to what happened at our institution. In the city, at some sites, 50% or more of the staff themselves got infected by COVID.
Yes.
In our first 6,000 patients, we had 3 of our staff get infected, and 2 probably got infected from their families. So mask work, the whole zoot suit thing that you had to do for protection, I think that was overblown.
Yes.
That mask ended up doing what it needed to do. But to be perfectly honest with you, we were flying the airplane while we were building it. We were trying to figure out from day to day, what's the new thing? Oh, today it's hydroxychloroquine. Well, it turns out that didn't work. Well, tomorrow it's ivermectin. Well, it turned out that didn't work. We were intubating people because they were severely hypoxic, even though they looked great. And then we started to stop doing that, started to prone patients. But all of this stuff was a work in progress. We were having Zoom meetings internationally, people from Korea, from Italy, from England, all over the place, to discuss what they were trying, what we were trying, and what seemed to work. So it was a rapidly changing and rapidly evolving thing. And then the vaccine came out. Whatever you want to say about the vaccine, I can tell you that 96% of doctors took the vaccine.
Yeah, we all did
too. Once the vaccine was out, when we would see patients come to the emergency department with COVID and they'd had the vaccine, their illness was almost invariably minor. The ones that ended up having to go to the ICU were ones that had not yet had COVID and also had not had the vaccine.
Yes.
So to me, it's unequivocal that masks protected us. And any evidence to the contrary is based on studies where half the group is told they don't need to wear a mask and the other half is told they should wear a mask. But there's no measure of compliance with how much they wore a mask.
Right.
But I can tell you that we brought our infection rate to practically zero by wearing masks all the time.
I think you're absolutely right. The mask was essential, and the vaccine was a major advance for all of us on the front line. It was a very, very important time. Now, were you at the center of the AIDS epidemic, and how?
I was. That's just when I was starting in emergency medicine. That's when the AIDS epidemic started. Mm-hmm. And for quite a while, we had no idea what was causing it. We didn't know how it was transmitted. We didn't know if it was infectious or something else. I didn't know if it was safe to touch the patient. I didn't know if it was safe to breathe what they were breathing or what would happen if I got a needle stick. Nonetheless, I don't know of any emergency physician that was declining to take care of these patients. All of us stepped up. However, that was not true for a lot of the rest of the medical community. Right. Sometimes it was very hard to get a surgeon to take out the appendix. It was very hard to get an orthopedist to take the hip fracture to the operating room. And even the AMA, I understand, sent out a policy that it should not be required that a physician be forced to take care of a patient with AIDS, that they should be able to choose to opt out. This is something I just was just horrifying to me to hear.
Yes.
But it was, I didn't go to work scared, but I went to work concerned. But the two illnesses were completely different. COVID is an acute infection. It can make you horribly ill and it can kill you.
Right.
The people with AIDS, it was like they were just slowly, the life was being dragged out of them, that they were just eaten away. I'd have a 6'4" guy that weighed 75 pounds, covered with tumor, having pneumocystis pneumonia, couldn't eat. At that time, people were trying the main help was to just try to get them some marijuana to stimulate their appetite and help them with nausea. There was really nothing that was effective to do for them. That was horrible. It was sad. And what a glory it was when we found medicines that could control it. And now if you have AIDS and you're adherent to your medicines, you have zero chance of spreading it to someone else.
Right. Which is an incredible commentary on the history of medicine in our recent, 3 decades. Let me ask you, for those of you who are listening or watching, please subscribe to this show and you will get more information such as you've just heard, which is extraordinary. Why do people in the emergency room wait so long to be seen? And we see this, everybody every Tom, Dick, and Harry or Mabel is watching an HBO special called The Pit, which is about an emergency room. And they see that people wait sometimes 6 to 8 to 12 hours. Sometimes we have patients that are in the ER for days. Why is that?
Well, there's a thing called math. This imaginary emergency department, we have 70 beds.
Yes.
Let's say that we built that emergency department to accommodate the volume that we projected that we would have. Now, over the years, the volume grew. So it gets more crowded and more crowded. There's more things that we do. Instead of everything taking an hour or two to do, now we're getting CAT scans, we're getting MRIs, consultants. There's a lot of patients that are there for 8 hours, 12 hours, because we're actually trying to diagnose them and possibly send them home instead of admitting them to the hospital. There's a thing that we started doing called observation medicine.
Yes.
Whereas in the past, if you had chest pain or a TIA or a fainting spell, which we call syncope, you would be admitted to the hospital for workup, and you'd be there for 3 or 4 days. Well, it's sort of a complex workup, but we can do that in the emergency department. It may take 12, 18 hours to do, but in the hospital it would have taken 3 or 4 days. So we can accomplish that in a shorter period of time. So we designed this emergency department, and then we changed our mission. We started having many more patients to begin with, and those patients had more complexity, and we were keeping them for a much longer period of time.
Yeah.
Now add to that we have boarding of admitted patients. You're sick enough, you need to come to the hospital, I'm going to admit you, but to where? There's no bed upstairs because they're full. Right. So you stay in the emergency department. And let's say I am at a given point in time in my 70-bed emergency department, I might have 140 or 150 patients there that are competing for those beds, for those 70 beds.
Right.
If I have 40 admissions sitting in the emergency department taking up 40 beds, I now have to accommodate that 150 patients in 20 or 30 beds instead of 70 beds. So that's what the waits are for. Now, if you collapse in the waiting room, if you come in and your blood pressure is low, if you have signs that you're having an active heart attack or an active stroke, or you have a massive trauma, we figure out how to see you right then and there. There's not a delay for those. But if you have belly pain, and it may turn out to be something very serious, but you'll wait longer than those other people. It's because we triage according to what we know is emergent, what we worry about is emergent, and then you look stable and we're sort of concerned about you, but you're not going to go in front of those people. So in some places the wait may be 12, 16, 24 hours. In most places, there will be times when it's just unraveled. And it may be because of boarding of admitted patients, and it may be because you just got slammed with volume that day. There was a bus accident or some other thing happened that just changed the game.
Right. Okay, so let me use an example which has been vexing emergency rooms. In the emergency room on a really cold night, the homeless gather for several hours, and they come and they sign in for care. And then at 2 or 3 in the morning, they leave without being seen. What do we do about this? Because the ER staff gets knocked for not having seen a patient that registered.
If they walk out before we see them, that's called left without being seen.
Yeah.
And that's sort of a reflection of that we didn't do a good job. And maybe it's because it's not possible for us to have done a good enough job because of the amount of space and staff we have to treat the number of people that are there. Now, there's this notion that, well, if you came to the emergency department and then you walk back out, you probably had a minor thing anyway. Mm-hmm. And that's not true. There's a certain percent of those people that actually end up needing to be admitted. There's a certain percent that have something very serious. And I have personally been told by someone, I came to your emergency department and I left because I was too sick to wait. Right. Imagine that. That's just insane. But it is what happens. We've tried to do all sorts of workarounds to make sure to at least minimize that. Variations like having a physician at triage or having an intake area where we can at least start your workup. We can get your bloods going. We can order a CAT scan or a chest x-ray. And then maybe by the time you get back into a room, everything's back and we're ready to go so that your length of stay is not much different than what it would have been if you'd gotten in right away. But it's a problem of, I think part of this is us lacking a clear mission of what it is that we need to accomplish. And what do I mean by that? We've evolved from emergency departments from 50 or 60 years ago. And they were under-resourced because basically you didn't do much in an emergency department. You either sent people home or you admitted them right away. So you didn't need a lot of resources. But things got more and more complex. People were there for longer and longer. The volume grew, the mission grew, but we were still designing emergency departments based on that old concept.
Right.
This theoretical 70-bed emergency department I'm talking about, I think it'd be better served as a 200-bed emergency department. And it'd include all the patients that we currently see. At our place, we would actually have extra beds if we had a 200-bed emergency department. But maybe our mission would change to, you know what, we'll hold, if I can avoid admitting you to the hospital by treating you in the emergency department for 24, 36, 48 hours to reduce those number of admissions, it would create a lot of hospital capacity. And you could actually function with a smaller hospital if you did that.
Right.
So I think this is I think we need to have a moment of reflection in our specialty where we stop and we ask ourselves, what should our place look like from our point of view, and what should it look like from the point of view of the patient? When the patient goes to a cardiologist or rheumatologist, they expect to be seen in private with you.
Right.
They don't expect you to be walking in the room and there's 3 patients and you're all sharing your stories together.
Correct. That's correct.
The surgeon doesn't operate in the hallway. And when they are in the operating suite, there's not 2 surgeries going on in that room. There's only one. I think that should become our vision, but it requires a whole reconstruction and re-envisioning of what our specialty environment should look like.
Well, there's been,
but it is an environment where you, at the moment in your life, you're having the worst time of your life. You want it to be a place that's flexible and responsive and capable.
I've heard over the years, I was chairman of medicine at 3 different hospitals, and the discussion over the past 10 years was that perhaps hospitals should become more acute. Emergency rooms should play a bigger role, and basically the hospital should be like a big ICU because patients can go now to urgent centers or the doc in the box on the corner and get care from an advanced practice nurse or even a physician assistant. How do you feel about that? Do they compete at all with emergency rooms?
What, urgent care?
Yes.
I think most emergency departments are very happy that they're there.
Yeah.
Because we're already overloaded with patients.
Yes.
But, one thing that it has to do with the practice, it has to do with the cost, it has to do with a lot of things that are intertwined. If you think back to when Medicare came into existence, I think it was 1964.
Yep.
When there was nothing much you could do for a heart attack or a stroke or that sort of stuff. The average life expectancy for a man was 67 years old, and Medicare started at 65. They didn't, at that time, there weren't CAT scans, there weren't MRIs. Medicine was simple.
Right.
So the projections of cost were simple. So now we all talk about the cost explosion and this sort of stuff, but we've completely changed what we can do. If you were as old as I was and saw rheumatology patients back in 1978, 1980, if you had lupus, you were probably dead at 18 years old. If you had rheumatoid arthritis, you had just severely deformed joints and you were always in pain and there was no good treatment for you. Ulcer disease was treated with Mylanta. So they're just, I remember having to guess whether, I had to figure out by asking about cycles and whatnot, whether or not somebody was pregnant, because we couldn't get a pregnancy test in the emergency department. You could send it, but it wouldn't come back for a day or two.
Yes, that's right.
So a lot of cost is because there's so much more that we do. And if you're living to 97 instead of 67, you got a lot of years worth of medical costs to cover as well. The other reason that things cost so much, I don't know if you want me to get off on this tangent, but the other reason that things cost so much, I love a study by Huey Reinhardt. He's no longer with us, but he was an economist at Princeton. And he did an elaborate study that looked at what we do compared to other countries. So do we do more CAT scans than somewhere else? No. Do we do more MRIs than somewhere else, or more surgeries, or more this or more that? The answer was not that we did more.
Right.
Just everything cost more. Exactly. The doctor costs more, the hospital costs more, the nurse costs more, the medicines cost more, the post-op care costs more, everything costs more. Right. And when you have insurance, that is the purpose of most private insurances is to make a profit.
Exactly.
And they make that profit by providing insurance. But they can't spend more than they collect, or else they're not making a profit.
Right.
Our nonprofit systems are Medicare and Medicaid. I don't know what the numbers are now, but about 5-10 years ago, the administrative overhead for commercial insurance was about 30 cents on every dollar. The administrative cost for Medicare overhead was 5 cents on every dollar. Mm-hmm. So if you take that difference and pooled it, you could cover a tremendous number of patients with insurance if you took the profit motive away.
Right.
We're not going to do that. Now, you're saying that, well, people want that insurance, but they are competing with people that can give a lot of money to politicians to vote otherwise. So it's hopefully we will get something like Medicare for all someday.
Yeah.
Because it's a horrible thing that we do to people that we don't have insurance for them.
That's right.
There are societal decisions we make. We make a decision that we want roads to be paved and for them not to be private. We want a police force that's not private. Right. We want clean water. There's a number of things we've decided as a society, we as a society are going to pay for them.
Right.
But somehow we've left your health and your life in the hands of profit-making industry, which I'm not sure. I would suggest that's not the right decision, but that's, again, my personal view.
Yeah, but that's a great personal view. I mean, this is a very hot topic because healthcare, according to the populace and the polls that have been taken, healthcare is the number one issue. It's a $7 trillion business per year to take care of people who are sick. And we're only talking about, and you're only talking about the insured, not the Medicare or Medicaid patients, the insured patients, those who are on Medicaid, which is always being cut back, and those on Medicare, which is an issue for the government is one thing, but then you have people who have no insurance, no Medicare, and as I mentioned earlier, no Social Security numbers in city hospitals who can't get out of the hospital because no nursing home is going to take them, no rehabilitation center is going to take them if they're illegal or if they're so poor they don't have even don't have a Social Security number and that's not available. But emergency rooms have to take care of those people.
And there's this you hear these discussions about illegal immigrants getting Medicaid or this sort of thing, which is not true. However, it is true that there's such a thing as emergency Medicaid. If an illegal immigrant comes and has an emergency that needs to be taken care of, we need to put the leg back on, we need to operate on the spleen or whatever. There is such a thing as emergency Medicaid, and the numbers is that 50 cents out of every $200 is spent on that. The other $199.50 is spent on us.
Right.
So that's a thing. You said it was $7 trillion.
Yes.
And if you want to talk about different ways of changing of how we are insured and how we're cared for, your starting point has to be, if it costs $7 trillion, it means that someone's on the receiving end of that $7 trillion.
Yep.
And they don't want it to change.
Right.
You know, I would like everybody to get insurance. Do I want my salary to be reduced? No. But it's everybody that's all of the pigs at the trough want to have their food.
Exactly.
And so they will do everything they can to preserve the status quo and prevent it from changing.
Right. And that's an amazing problem that we have in this country. Let me ask you, for many years, hospitals in this country have been trying to alleviate ER boarding by doing fast tracks, dividing patients into groups, etc. Is there any logic to this going forward? Like, say, over the next 10 years, do you see substantial changes in the way we take care of people and the way that hospitals operate?
So I first would have to say it's illogical. If your problem is with boarding, then you have to solve that by getting them upstairs.
Right.
So these are things to solve our internal problems. If I need to improve my internal flow, then I may need to have a fast track so I can separate that group and get them out quickly. But I also need to look at things like what's the turnaround time for radiology, for labs, for consultants, all this sort of stuff.
Yes.
In order to shorten the stay of those that are discharged. Because since we're discharging at least 70% of our patients, if there's quicker turnaround time on them, then we get a more available space. So there is obviously sense in trying to make our system work as best it can, but you absolutely cripple it if you take away half of my space.
Right. Exactly. Should the emergency room have more beds? As I mentioned earlier, people are talking about having hospitals like big ICUs, and meaning that more acute medicine, more need for acute care beds, getting the people out of the hospital that should have a length of stay, say, of 1 or 2 days rather than 1 or 2 weeks, which is often the case. A lot of hospitals can't control their lengths of stay. For the public out there that don't know anything about length of stay, length of stay is the time that it takes for doctors to treat your illness and then get you out either to rehabilitation, to a nursing home, or to your primary care physician. So what do you think of that? The ER having more beds. You already said that you had 70 beds, and maybe they should have 150 beds where you are.
So I try to anticipate the future also. In terms of length of stay of people in the hospital, why do you get admitted to the hospital? Mostly it's because you need monitoring, or you're too sick to go home, or you need some kind of intervention to keep you safe. On occasion, you're admitted for diagnostic reasons, and that more and more has remained in the emergency department, as I talked about earlier, like working up the TIAs or the syncopes or the chest pains, just doing those workups in the emergency department instead of upstairs. So that's one reason that you are in the hospital. The other is the inefficiencies of hospitals. For instance, in the emergency department, if I see a patient, I want the test now, I want the results now, and I want to act on it now. It doesn't matter if it's 2 in the morning or 10 in the morning. Whereas hospitals tend to be, let's round in the morning, we'll order stuff, and then we'll look at it tomorrow morning when we round again. And there's a lot of opportunities there for getting stuff done more quickly if conceptually people wrap their head around that. There was an example, there was a previous chair of emergency medicine up at Rochester that took over a medicine unit and ran it with her philosophy, which was, I want the test now, I want the results now, I'm going to act on it now. And her length of stay averaged 2 days less than a regular medical ward. So
Yes.
I think there's a lot of opportunities within an institution to move things along better. And it's partially crippled by not having ancillary services available in the evenings or on weekends, or not running full force like operating rooms or cath labs or whatnot, not on weekends. So that we're, again, trying to solve a 7-day-a-week problem with very sick patients with a 5-day-a-week solution.
Right.
And it's just, at some point, we have to change.
You said that at the very beginning, and I fully agree with you. There's been a lot of discussion out there about having a specialty hospital such as bone and joint, orthopedics, rheumatology, cardiovascular, renal disease, have specific hospitals dedicated to these diseases, and having one giant emergency room. I've actually heard this as a business model, a giant emergency room, and then farm the specialized problems out to these other hospitals to make things more efficient. For example, instead of having a kidney transplant in 5 hospitals within a 50-mile radius, it would be good to have one hospital just to handle kidney transplants. There would be less waste of kidneys, and there would be more expertise at that specialized hospital. How do you feel about that, being an emergency?
So I would disagree with. I agree with the notion that you may have hospitals that are tertiary care facilities that are the ones that do kidney transplants, and that community hospitals don't. I agree with that concept.
Right.
But the problem with the concept is patients are so complex now that there's so much overlap in illness that to have what is a pure kidney failure or pure orthopedic problem, they're just not pure anymore. We see a lot of orthopedic problems in people that have very complex problems with their diabetes and their hypertension and their heart disease. So you need the cardiologist there and the endocrinologist. You need all these specialists. It's a whole mix. I would almost go in the other direction, that all the beds in the hospitals should be run by hospitalists, and then everybody else is a consultant. And the hospitalist integrates what the surgeon plans to do, and the orthopedist and the kidney doc and the endocrinologist and the cardiologist and whatever else. I think that that's a better model than, there are specialty hospitals and orthopedics, and if nothing else, I know 2 things about them. They're great, and they make a lot of money.
They do.
And
Right.
that's really I think the underlying argument for why don't we create a special orthopedic hospital?
Right.
But they're not going to take care of these sort of complex patients.
Right.
So why not just have good tertiary care facilities that can provide that care in a necessary way?
Well, I think you hit the nail on the head. One of the things that I always advocated as chair of medicine was to have hospitalists. And these are doctors. For those of you who don't know what a hospitalist is, these are doctors trained to work in the hospital to make it more efficient, to get patients out sooner, to get patients treated sooner. And they obviate the 5-day-a-week hospital. The hospital, as we both said, should be 7 days a week. Testing should be round the clock. Care should be round the clock. It shouldn't be where the surgeons stop operating on a Wednesday or a Thursday because they don't want to see the patients on a weekend. And that actually happens in some community hospitals, which makes them very much inefficient. What do you think about that?
Oh, I think having a complete hospitalist service is the way to go in the future for patients, because then they have a voice that can integrate 10 other voices, and it can make sense to the patient, because otherwise it's just too overwhelming.
And most specialists don't want to come to the hospital 10 times a week and see patients in the middle of the night. They'd rather depend on the hospital. So that's how medicine has changed, on the hospital.
Also, the other thing that's changed in medicine is, as we have a growing population of debilitated, chronically ill patients, once they're in the hospital, they may not be able to go home safely. They may need to go to a rehab place, or they may need to be placed in a nursing home admission. And there's several problems with that. One is, do we have enough beds in rehab places and in nursing homes in order to accommodate the volume of patients that have that need? The second thing is, there are all sorts of games for people that have insurance. There are all sorts of games that the hospital has to play in order to get a patient into subacute rehab or into a nursing home. They have to submit all this paperwork to insurance companies, and insurance companies then have to approve the transfer, and they almost invariably do. But they'll screw around with it for a couple of days or even a week before they give you the approval, and then during that time, the bed's tied up. And then there's also the problem of people with severe psychiatric and behavioral problems, where sometimes there's just not a place that's going to take them.
Right.
There's just not a place that's going to take them, and they end up living in the hospital.
That's right.
And this is an epidemic problem in hospitals throughout the country.
That's very, very true. You've hit on some major, major issues. Now, years ago, in some of the large urban hospitals, there were things called stat clinics, and they were outmoded. And the stat clinic was, after triage, the patient was, if not significantly affected by an acute illness, would be sent to the stat clinic the next day. And we have clinics in many of our large urban hospitals which handle the indigent, the poor, etc. What about that? Should they be increased in size? And should that stat clinic take the place of, say, the urgent center, where one has to have money to be cared for?
It is certainly something to think of, particularly in where you have an inner city public hospital that has may have a very large population of patients with that need. That a stat clinic makes a great amount of sense. If you can get people timely referrals, though, in different, maybe in a different community, I don't know how much that would help. But in the right setting, I think that's a fantastic idea. I think it's dangerous just to sort of from triage send them there, because they may have something cooking that's far more serious. You know, a good friend of mine who died recently had a famous, two famous sayings that I loved. One was that the biggest obstacle to the correct diagnosis is the current diagnosis, which I thought demonstrated a great amount of wisdom. But the other thing he said about emergency departments is, he says, you know, only 5% of the patients that come here actually need to see a doctor. The problem is, you don't know which 5%.
Exactly. Very interesting stuff.
You were talking. I wanted to mention about the speculation about how we'll grow, or should we really have this huge emergency department. What I imagine happening, based on how much I've seen change in the time I've been doing this, and the growth of AI and all this sort of stuff, and nanobots and whatever. What would I speculate is happening in an emergency department 10 years from now? I'm going to speculate that a lot fewer patients need admission to the hospital, because they're going to get their treatment in the emergency department, and the treatments are going to be amazing. You come in with your first case of diabetic ketoacidosis.
Yeah.
Your body can't make insulin anymore. So we send a test down to the lab, and they send back up some pancreatic islet cells, which are specially made that we can just transfuse them, and you don't have diabetes anymore. Or you come in with an occlusive MI, and I just inject nanobots in you, and they go and chew up the clot, maybe chew up some plaque while they're at it, and then you go home in a few hours. EKGs, I don't think physicians will be looking at in the next few years. It'll be done by artificial intelligence. Yeah. Radiology has major threats against it in terms of artificial intelligence being able to read and very competitive to how they read. So I think that there are just dramatic changes that will shorten the need for prolonged care. And maybe we'll have a whole box of health monitors that we just strap on a patient, send them home to monitor their sodium and their glucose and their heart and all this sort of stuff in an integrative way. So the computer will say, when you walked up the steps that time, your heart rate increased by 17 beats, which means you're having worsening failure. So you need to come and get an infusion of something in order to fix that. I think that there's some amazing things that can potentially happen. I will throw a plug in, though, for research. Yes. If these things happen, if you fund research to make them happen.
Right.
If you don't fund research and you just decide that medicine can be answered by Instagram and TikTok, then so be it.
Yeah, and we don't want that to be said, that Dr. Google, ChatGPT, and TikTok is no way to have a diagnosis made. We have lots of patients that do that. And I use the example of somebody who had a husband that had a tremor in one arm, and she said he's got Parkinson's. And the poor guy lived for weeks with the presumed diagnosis of Parkinson's when, in fact, he didn't have Parkinson's. But she couldn't get to take him to a neurologist because neurologists have a 4-month backup for an early appointment.
Yeah.
So it's really—
My sister recently died of multiple sclerosis. She'd had it for about 40 years. When she had her first symptoms, I told her, this was what it sounds like. It took her almost a year to get an MRI approved.
Oh, boy. And that's an example of, catastrophic healthcare. You can't take care of patients when you can't get testing.
Well, the whole approval system is, I think the fundamental logic of approving me to get an MRI or a CAT scan or something like that is if you make it difficult enough for me to get the approval, at some point you just give up. So you know what? If I'm the insurer and I have to pay for that test and I can get 50% of the people that actually need it to give up,
right,
then, good. My shareholders will be happy.
And that's what we're seeing. And we should do a show here for Health Frontiers just on insurance companies and authorization of both tests and drugs. So, Peter, we're running out of time. And I just want to say, for those of you who are listening or watching, please subscribe to this show so you'll see many of our more interesting programs, such as this one. Let me end on a good and happy note, which is everyone is glued to their HBO that has HBO to watch the show The Pit. What do you think of the accuracy of The Pit?
I think that the medical accuracy is dead on. I have personally had almost every case that they've shown in there at some point in my career, and their approach, the administration of procedures and medicines and doses and everything, I think almost always are more dead on than any other medical show that I've ever seen in my life. I feel like if somebody doesn't know what I do, I want to take them by the arm and say, "Come, let me show you what I do. This is what my day's like." Now, obviously, they compress a lot of stuff into one day.
Yes.
But sometimes you can have days like that.
I know,
where it gets that crazy.
Especially with an MCI, which is a mass casualty event, for example, a shooting, which was illustrated on that show, and some of the other events that happen. This is very realistic. I watch it when I'm in the gym, and it's extremely exciting. Do you have any final words you want to impart to our audience before we sign off?
So one thing about mass casualty events is when you do have a mass casualty event, everybody wants to participate. So you get everybody from upstairs coming down to help you, and they want to be a part of the story. What you are seeing in the pit is a slow burn mass casualty event. It's just that the daily work is a mass casualty event, and they don't get special attention for it. It's only when it's something that's exciting and big, now you get everybody involved, and it's a great thing. I have loved doing what I do. My best part of my week is to do a shift in the emergency department. I love working with my residents. I love seeing patients. And but it's really a barometer of our society. It's a barometer of the failure of our society to protect our citizens and not have, so that they do not have, a lot of people do not have adequate care. And we are almost every shift discovering some new terrible disease in some individual that we saw that day. They came in with a little bit of belly discomfort. They hadn't seen a doctor for a long time, and lo and behold, they have metastatic cancer or something like that. It's just tragic, and I just wish that we could do better, because I know we can do better if we put our minds to it.
And that's a great way to end this show. I want to thank you, Dr. Viccellio. This is Dr. Peter Viccellio, who is the professor of emergency medicine at the Stony Brook University Medical Center on Long Island. And this has been very exciting and a very informative program. And I want to thank you for being with us. And I want to tell our viewers and our listeners to please subscribe to our show. Peter, thank you so very much.
And thank you so much for having me. It's been an honor.
Thank you.
Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.